Good evening, everybody. My name is Teresa from the Viva Foundation for Children with Cancer. I'll be hosting tonight's webinar, The ALL Landscape in 2020. The webinar is organized by Viva with the support of Amgen through an educational grant. For those who are new, Viva is a charity focused on saving the lives of children with cancer through excellence in research, medical care, and education in Singapore, Asia, and beyond. So every year we organize educational exchanges amongst doctors, nurses, and other medical professionals, such as through our annual St. Jude Viva Forum in close partnership with the St. Jude Children's Research Hospital in the US. So we hope that tonight's webinar will be meaningful for everybody and that it will contribute towards saving more lives of children with cancer. For those who are new to Zoom, as I mentioned in my earlier notes, please do share your questions in your Q&A box located on the bottom of your webinar screen. And there will be a dedicated Q&A session towards the end of the webinar where we will try to address as many questions as we can. So in the interim, I'd like to invite Viva's Chief Operating Officer, Mr. Anson Chu, to say a few welcome remarks. Anson?
Hi, good evening, everyone. Yeah, my name is Anson Chu. Thanks, Teresa, for starting this. I'm the new Chief Operating Officer of Viva. I'm quite new. This is my second week in Viva, and I'm excited to have a chance to meet everyone. Tonight, we are very happy that this webinar is organized as part of our mission to share the latest in leading-edge research and treatments in pediatric cancer amongst medical professionals like yourself. Okay, Viva believes that these exchanges are vital in enabling children to access better treatments as doctors also gain new knowledge from their peers. So it's a very important sharing and bringing people together for this common cause. Okay, Viva has organized 4 webinars since March in response to the ongoing COVID pandemic to ensure that the continuing education of medical professionals are not affected. Okay, so although we are unable to organize our annual St. Jude Forum, we have moved into these webinars to continue the spirit of sharing. And so far, these webinars has been very well received, and we averagely have about 200 to 300 registration for most of the webinars. And of course, the actual participants usually will range about 100 plus to even 150. Yeah. We will be doing more in the next few months, and with 3 more webinars scheduled in October. And we are very open to suggestion from anyone for any new topics and even ways that we can improve on our webinars. So I'm very happy to announce that we are very fortunate tonight to have with us a very distinguished and esteemed experts, a panel of experts who are here, and they are also people who are very at the forefront of their own fields. So I'd like to acknowledge and thank Dr. Rajat from the KK Women and Children Hospitals, and then Professor Inaba from St. Jude Children's Research Hospital, and Professor Vaskar from the University of Manchester. I really thank all of them for generously lending their time and expertise to us tonight. I will leave it to Teresa to give more detailed information or introduction to the experts and their background. Okay, Teresa, to you.
All right, thank you, Anson. It's with great pleasure for me to introduce our chair moderator for tonight, Dr. Rajat Bhattacharya from KK Women's and Children's Hospital here in Singapore. Dr. Bhattacharya is Senior Consultant at the Pediatric Hematology and Oncology Service at KKH and is a Senior Consultant also at the Duke NUS Blood Cancer Center. He did his undergraduate medical training and postgraduate pediatric training at the Medical College, Kolkata in India, and pursued further pediatric and hematology training in the UK. He also completed his specialist registered training there. He was also a fellow at the Vancouver Children's Hospital in Canada before he joined KKH in March 2013. His special interests lie in malignant hematological conditions, stem cell transplantation, and cellular therapy. So I'd like to turn over the floor to Dr. Bhattacharya, who will introduce our webinar topic for tonight, as well as our main speakers for the evening.
Right. Thank you, Teresa. You can hear me, right?
Yes.
So welcome everybody, and good morning to anybody who's logging from US, and afternoon to somebody from Europe, and most of the attendees are, I guess, from Asia. So good evening to all of you. So I must first thank Viva for organizing this webinar, and also Amgen for supporting our webinar. I know there's a webinar Sumanami going on now, but this is a very special webinar. I think it's a pediatric ALL in 2020. And to have got two excellent speakers, there's a stalwarts in the treatment of pediatric leukemias currently, Professor Hiroto Inaba from St. Jude's and Professor Vaskar Saha from Calcutta. Well, he was in UK 2 days ago and he's in Calcutta now. So to introduce the webinar, acute lymphoblastic leukemia is a bread and butter of our pediatric hematologists oncologists. And it's a great success story from 1960s, being 0% success to 90% success rate in 2020. However, all of us, we face some children who have a high-risk features and they either don't respond to treatment very well or they relapse after treatment. And this is the challenge to manage these sort of children. So we know that the conventional chemotherapy with the risk-adapted therapy has achieved a significant success, and we have achieved a 90% cure rates, but the cure at least cost stops somewhere, and there lies the issue, do we have some other therapy? So main the focus of this webinar will be to introduce the concept of the immunotherapy in this sort of high-risk group to prevent relapse, and what to do if the relapse after the initial treatment. So as you know, we have two great speakers. I'll introduce the first speaker, which is Professor Hiroto Inaba. He's from St. Jude's Hospital, US. He's a member of the Leukemia Lymphoma Division. Professor Inaba is an MD and PhD from Japan. And he went to St. Jude's Hospital. He was meant to be there for 2 years only, and he was meant to return to Japan, being the eldest son. He was meant to hold the family, but I think he never went back because either he liked St. Jude's very much or St. Jude's never let him go back. Many of you may not know that Professor Inaba actually comes from a samurai family. He's a 17th generation samurai, but his first name is Hiroto, which means a flexible samurai. Coincidentally, he's also running this Total 17 protocol, which is running in St. Jude's, and he's continuing the samurai fighting spirit with his fight against leukemia. So Professor Inaba will talk about the concept of immunotherapy in acute lymphoblastic leukemia and see how that can advance the care from being 90% cure rate to 100% cure rate. I guess that's the motto there. Apart from being very flexible, which is Hiroto, he's also very, very nice and gentleman. He's very approachable. He has been helping us and many other oncologists across the world throughout his career. And thank you, Hiroto, for that help you're offering to all of us. I will hand over to Hiroto. And just another thing to mention that when the Q&A session, when you post question, could you please just mention which speaker you want to answer that question possible. So Hiroto, I will hand it over to you.
Thank you, Raj and Teresa and Biba and everybody. And let me share my screen. Thank you very much for the opportunity to talk about ALL treatment. I focus on immunotherapy. I'm Hiroto. I'm a leukemia division from St. Jude. And this is my disclosures. And this is a survival curve of total studies. And total 15, we had a 93.5% survival. And then this was made possible by optimized dosing schedule of conventional chemotherapy. And then we had a better risk stratification by using clinical risk factors, age and WBC, and cytogenetic and genomic analysis. And then we started using MRD from late 1990s. And then we individualized chemotherapy by doing pharmacodynamic and pharmacogenomics studies. And then we have much better supportive care in the recent studies. And then we recently published total 16 and survival was 94.3%. So no significant difference in terms of survival between total 15 and 16. So, we have been using most of the patient conventional chemotherapy. And then we feel that the intensity of chemotherapy is coming to the limit of tolerance. Means if you increase chemotherapy, it may not able to increase the survival, but maybe increase also toxicities. So we have to incorporate newer agents which were approved much later after 2000, such as imatinib, dasatinib, ponatinib, such as TKI, or immunotherapy. So when we plan total 17 actually current trial, we discussed couple issues, and we should prospectively, comprehensively analyze genomics in the ALL. So and we can divide to many genetic subgroups, and also we continue to monitor MRD, and then we discussed we should combine with genetic subgroup with MRD for comprehensive risk stratification. And then, if feasible, use molecular target therapy and immunotherapy. In total 17, therefore, we take the germline tissue to check whole genome and whole exome, and then leukemia, whole genome, whole exome, RNA-seq, and then with the help of computational biologists, we do digital karyotyping, which replaced conventional karyotyping, and a structural variant, SNP in there, and copy number changes. And we meet every week to discuss each case of what's a subgroup, what the genetic alterations are. And now ALL is divided by many subgroups, more than 20 subgroups, which meaning we can classify lower risk group, intermediate group, and higher risk group. And among these, BCL-ABL1, BCL-ABL1-like ETP, about 10% patient can be targeted. Only still 10%, hopefully that increase more. So at this moment, we do bone marrow and skin biopsy at diagnosis. And then RNA-seq will be done by day 15 and add dasatinib for ABL class fusions. And the whole exome, whole genome done by day 28. If no targetable region and high MRD on day 15, we use bortezomib. And then for JAK-STAT alteration plus high MRD or ETP, we use ruxolitinib. But importantly, other approach is immunotherapy, such as Brina, CAR T cells can be single CAR T, or sometimes people considering bispecific antibody inotuzumab or rituximab. And the T cell immunotherapy is still in a preclinical or early phase studies, but there's CAR T cell or antibody. And these daratumumab, and alemtuzumab, very difficult to pronounce these antibodies anyway. So these are people start using, for example, daratumumab for the T cell LL in COG. For B cell LL, so now major leukemia groups start using immunotherapy in the frontline setting. And COG is using Brina for standard risk, inotuzumab for high risk, and the BFM IOP use Brina for intermediate and high risk. And ALL together, this is a newly established European group, is using inotuzumab for intermediate risk. And all the group are using CAR T cell for very high risk group, which means MRD persistent disease. So they are using a similar protocol for the CAR T cell for very high risk. So now, immunotherapy, I mentioned that Brina, inotuzumab, and CAR T cell, and they have unique side effect. Blinatumomab have a cytokine release syndrome, neurotoxicity. Inotuzumab is very similar to Mylotarg because the antibody is bound to karikemycin, which is chemotherapy. And then as we saw in the Mylotarg, that can cause sinusoidal obstruction syndrome, the other name BOD, veno-occlusive disease. And CAR T cell, similar to Brina, cytokine release syndrome and neurotoxicity, and all can cause low immunoglobulin, hypogammaglobulinemia. But for that one, for CAR T cell can be more long-term and can be, as long as T cells present, can be permanent. And then, or long-term. And then, so we discussed how to use immunotherapy in the BLL. And then we decided at least we should consider patient who has MRD positive at the end of induction. So in total 16, excuse me, 89% had MRD negative, means 0.01% or less. We continue chemotherapy. 0.01 to 1%, about 9.4%, we continue chemotherapy. And more than 1%, 2% of patients, we consider transplant. So we check the relapsed refractory disease. And both 0.01 to 1% actually had incidence of about 20%, 19.2 and 20%. Although the 0.01 to 1 had later relapses, so can be more salvageable compared to more than 1%. But we discussed these patients can benefit from the immunotherapy. However, majority patient MRD negative and still 5% relapse. So, we investigated more. And Dr. Pui published a couple years ago that MRD level and genetic subtypes. And he combined these factors. So for the low risk patient, MRD negative, relapse risk was about 5%. This is a total 15 cohort. And of course, MRD become high, relapse risk is higher. And importantly, standard risk patient, of course, MRD high is associated with a relapse risk. But even MRD negative in these groups had still more than 10% relapse risk in the total 15 cohort. 190 was mostly at that time CNS relapses. We overcome with a total 16 by giving more frequent intrathecal chemotherapy. But even if end of induction MRD negative, patient with NCR high risk BLL and T-cell still relapses. So, we also went down among these subgroups, even MRD negative, which one has a risk of relapse? We investigated MEFT2D, hypodiploid, BCL1, KMT2A, rearranged, BCL1-like, and IMP21, also very rare, but TCF3HLF, and BCL2 rearranged, and MYC rearranged, and Down syndrome. Majority Down syndrome, many of Down syndrome belong to BCL1-like. But these one, the patient, even MRD negative, still has a higher risk of relapses. And then we decided to use immunotherapy for these patients, except KMT2A, because we're concerned about linear switch. So we group this group as high risk genetics, even MRD negative and others. These are all MRD negative patients at the end of induction. And the EFS, not the high risk group, has very good EFS compared to 82 and 78 at 5 years and 10 years EFS respectively for high risk genetic features. Overall survival was almost all survived if MRD negative in other group, but the high risk group had worse overall survival. So we decided also this group should maybe benefit from immunotherapy in the BLL. So in the BLL, in total 17, we are using immunotherapy if end of induction MRD more than 1% or above, MRD 1% or above, we use CAR T cells. And then MRD 0.01 to 1%, or MRD negative, and then high risk genetics that I mentioned, we use Brina. So for CAR T cell, we take the cell from the patient, and then T cell receptor is transduced and expanded. And after chemotherapy and T cells given, this is many people may know. And this is also important study from international, 75 patients, survival was 81, overall remission was 81%. This remission persisted at 6 months in 80%, and then 59% in the 1 year. 1 year EFS 50, OS 76%. B-cell aplasia at 6 months, which is the indirect marker of CAR T-cell persistence, was 83%, and CRS is very high, 77%, and quarter of the patient had grade 4, very severe cytokine release syndrome. And neurologic side effect was grade 3, was 13%. In this study, only 8 of 75 patients went to transplant. So we have an expectation that CAR T cell can replace transplant. Maybe we can conclude chemotherapy after CAR T cell and monitor. And we hope that. But some groups have some concern because there is resistant mechanisms. And some people may consider bridge to transplant, but we are not thinking at this moment. We're just trying to conclude. But there is a mechanism of resistance in CAR T cell. For example, loss of CAR T cell persistence and B cell aplasia. Maybe because low leukemia burden at the time of CAR T, or co-stimulatory molecule is maybe different. 4-1BB seems better than CD28. And the immune-mediated rejection partly may be murine component. And then if CAR T cells made from early lineage T cell or differentiated T cell might be different, or fresh product or frozen product might cause difference. And also target antigen loss is reported, and there's a mutation of the CD19 exon 2 to 5. And lineage switch can happen. ML rearranged or GNS84 or PH1 are reported for lineage switches. And phagocytosis, CD19 molecule is taken to the CAR T cell. CAR T cell express CD19 now, and another CAR T cell attack CAR T, phagocytosis has been reported. And also introduction of CAR gene to BLL has been reported. And previous use of Brina inotuzumab probably decrease the effect of the CAR T cell therapy. So many people are working to overcome this resistance for loss of CAR T cell persistence. Maybe people think, maybe low level MRD might be appropriate. They need some disease for CAR T cell expand, MRD 1 to 10%. Maybe some people consider 2 co-stimulatory molecules or lower binding affinity to target from UK group, and humanized CAR T might be better. And many people are thinking that in vivo stimulation with CD19 vaccine or cytokine to enhance the persistence. And then some people may say fresh product is better, not freezing, and then generate from the early T cell lineage cells. And for target antigen loss, some group are using bispecific CAR T, CD19-22, or multiple CAR T, CD19, CD22 CAR T cell protein. And also very important to check the evaluation of CD19, CD22 expressions on ALL cells prior to CAR T cell infusion. Blinatumomab is a CD3, CD19 conjugated antibody. One side bind to T cell and activate, the other side bind to leukemia cells and CD3 cell attack CD19 and kill it. And also T cell proliferate and then cause cytokine release syndrome. This is the adult study randomized chemotherapy versus blinatumomab. And blinatumomab had a better survival, although at the end, it's a curve crossed, a curve merged, but survival is longer, and remission rate was higher, MRD negative rate was higher, and then less neutropenia, less infection, and CRS was about 5%, and there's no difference neurological side effect. But maybe in a lot of disease, maybe blinatumomab has some limited activity, might be. But there's a large adult study show that MRD positive ALL can become MRD negative, and Blina can increase the survival in the MRD setting. I was also interested in this study published in 2012, only small number of patients with adult MRD positive ALL. In this study, relapse-free survival 61%, and 9 out of 20 went to transplant. At the 30 months, survival 65%. But I thought this is interesting. 11 out of 20 didn't go to transplant, but 60% alive without transplant after that. So blinatumomab may be effective in earlier stage of disease or low level of disease, and most likely less CRS with a low leukemia burden. So we are wondering, blinatumomab use MRD low level and then continue chemotherapy in the frontline, maintenance therapy in the frontline setting, maybe may cure the patient. So also pediatric important study presented ASH last year, and then relapsed BLL, intermediate and high risk patient, and the chemotherapy was given all patients to decrease leukemia burden. This is the R3 regimen. And then block 3 was given as R3. And this was Dr. Saha led in the UK, actually, this regimen. And also the other group was used Brina, and then all plan to go to transplant. There's a significant difference in disease-free survival. P-value actually 0.05, but difference. And then significant difference in the overall survival much better in Brina, and then better MRD clearance, better transplant rate, and then no toxic death instead of 4 any others chemotherapy. And look at this number, fever neutropenia grade 3 above was only 4 versus 40%. And then infection 10%, 40%, and much less sepsis and mucositis. And then because leukemia is reduced, cytokine release syndrome was only 1% for grade 3 above, and the seizure was only 1% above. So, this was done very, safely compared to chemotherapy, and the better outcome was seen. So we, our study now, we are using immunotherapy for selected patient for BLL. And then, for low risk patient, for small number of patients such as PH-like or Down syndrome, for worse genetics, MRD negative, we use Brina. And also standard risk patient in our criteria, worse genetic or MRD 0.01 to 1% with Brina, and going to maintenance, continue maintenance and complete therapy. And then, looks like these patients, we have a 10 weeks break between these chemo. Before going to maintenance, they have much better shape rather than just continuing from consolidation to maintenance. So this is helping to recover the patient for general condition as well. For high-risk patient MRD more than 1%, we give CAR-Ts and try to conclude therapy by monitoring CAR-T cell persistence. Our number is small, so it's hard to say at this moment. And then, we are doing this, but I noticed that when, in the Viva forum last year, and Dr. Caneva and Alcazabas from Philippine General Hospital was presenting their data. In, excuse me, 2003 to 2007, they were using high-risk in-house regimen. And they had a toxic death of 44%, 1 year survival was 32%. And then they decided to use a PSYOP PODC regimen, one very essential component of ALL therapy, not intensive. Their toxic death decreased 17%, and 1 year is 71% survival. And then usually go to regimen 2 and go into regimen 3. When they use regimen 2, toxic death further decreased 9%. And then 1 year survival is 80%. And then, she also showed EFS, NCI standard risk patient EFS was 51, NCI high risk patient 42. So I think there's a lot of room to improve from this number. Then we maybe thought that, I thought that actually further intensification maybe improve more, but also associated with a more toxicities. So, we wonder that, we maybe whether we can use some immunotherapy such as Brina can be used in the low medium income countries. This slide was made by Caitlin Duffy, who is an excellent fellow in St. Jude. And she said, we have to overcome many issues. We need to select the patients. We need to, good protocol design. We should have health system capacity to confirm better supportive care, logistic, cost, very expensive medicine, and we need clinical expertise. We need the teaching. But we discussed, we just asked Amgen, you are interested? And, they are interested. So we decided to collaborate, St. Jude Global and Amgen, and of course, Viva to work in locally. And then, direct relief, who can deliver medication to these countries. So we are starting this program to, collaboration, starting from India, Pakistan, and followed by Vietnam. We're planning, Vietnam or Philippines, Indonesia, or other Southeast Asia countries. And hopefully this is going to help patients here. So at the end, this strategy is not proven yet, but hopefully this strategy improve. Our goal is to identify leukemia subtype by prospective analysis and sequencing. And then we, of course, monitor MRD and use still clinical factors. And then, combine these factors to make a comprehensive risk stratification, and then incorporate target therapy, such as TKI. Now, other agents, venetoclax, navitoclax, or many agents comes, and hopefully we can add more to improve for this part. And also immunotherapy, for the persistent MRD or high-risk genomic features. Hopefully we can bring more to decrease chemotherapy and more effective therapy can be done in the near future. Also, hopefully we can use, globally, these kind of immunotherapy or target therapy in the patient with ALL to improve the survival and decrease toxicity globally. Thank you very much. This is my end of talk. Thank you very much.
Thank you so much, Hiroto. Wonderful talk. So after that wonderful talk, our next speaker is Professor Vaskar Saha. So Professor Vaskar Saha is a professor of pediatric oncology in the University of Manchester, but he's also head of pediatric oncology and the director of the Translational and Research Center in Tata Medical Center in Calcutta. I don't know how he manages both jobs, but he does. He's also the Wellcome Margdarshi Fellow, and Margdarshi means a person who shows the way. So he's actually been the person who has shown the way how to investigate and treat children with relapsed refractory acute lymphoblastic leukemia. He is a PI of the well-known R3 and the IntReALL trial protocol. Born in UK, but his medical training, graduation, post-graduation has been in CMC Vellore, Christian Medical College Vellore, and further training and research has been in UK. However, he has been coming back to India to work in Tata Medical Center for part-time, and he's also running another trial called ICICLE trial, which is a pan-India standardized protocol for treating acute lymphoblastic leukemia that has already been running very successfully, and it has already shown its beneficial effect and increasing the survival rate in children in India. A translational researcher and a man of incredible knowledge, talent, and energy. So Professor Saha is going to talk to us about relapsed acute lymphoblastic leukemia and mainly the lessons learned from the R3 trial. And he's also going to touch on the lessons which have learned from R3 trial and how he's incorporated that knowledge, and he's designed a treatment protocol for relapsed ALL in Tata Medical Center in Calcutta. And hopefully we can adopt and learn something from this because this is a protocol which can be used for relapsed ALL in resource limited centers, and we can think about that. Whatever I'm going to say about this person is going to be not enough, so I'm going to shut up, and then Professor Saha, the stage is all yours.
I think, thank you, Dr. Bhattacharya, for your kind and exaggerated words. I'd like to thank Viva and Amgen for organizing this symposium and for inviting me to share with you today some of the experiences in relapsed acute lymphoblastic leukemia of childhood gathered over the last 2 decades in Europe and in India. And this is just my declarations. So I think that as most of you know, there are 3 main prognostic features for relapsed acute lymphoblastic leukemia. The most important of this is when does the child relapse? And hopefully you can see my cursor. So you can see that about 40% of patients, and this is the group that has the best outcomes, relapse more than 6 months after stopping treatment. But you can look at the bottom of this, you can see that childhood ALL relapses and continues to relapse even 10 years later. Okay, so that's just something to remember. This group of patients who relapse while on treatment, which is about 1/3 of patients, has the worst outcomes. And then there's this little intermediate group which relapse with 6 months before or after stopping treatment. Now, along with that, we also have different sites of relapse. So as you can see here, the isolated extramedullary relapses occur primarily on treatment, but the bulk of relapses are late bone marrow relapses. And the third prognostic feature is the immunophenotype. T-cell ALL does worse, but as you can see here, T-ALLs predominantly relapse while on therapy. Proportionately, the T has a much higher incidence of extramedullary relapse with a small proportion of late bone marrow relapses. Now, this is just to show you the outcomes of late isolated extramedullary relapses. This is data both from the COG and from the UK. This has been fairly stable, not much improvement in the last 3 decades. And for today's talk, I am not going to talk any further about isolated extramedullary relapses. I just want to talk about two different types of relapse. One is the late bone marrow relapses in BCP-ALL, which is the commonest type of relapse, which is what Professor Inaba was also talking about. He's talking about directed immunotherapy. This is a group that's applicable to. And this is a Kaplan-Meier curve taken from the BFM. They published it early in 2000, where they treated patients with chemotherapy and radiotherapy, and they observed that patients who had an end of induction MRD of less than 10 to the power minus 3 had a significantly better outcome than patients who had a higher MRD. So we'll discuss that group, and we'll also discuss this group. So this is the high-risk relapse group. And the high-risk relapse group we classify as anybody who has a combined or isolated bone marrow relapse for a BCP-ALL. This is within 6 months of stopping therapy. So, and for TLL, it's at any time. And what these curves show you is the different outcomes in different BFM trials. And you can see there's very little improvement in outcome, resting at about 20%, okay, after 3 decades. So these are the two groups that we would like to study, and we will talk about. So this is where we were in 2000. And so early 2000, the BFM and R3 groups came together. So saying, okay, let's try to work together to find some common strategies. It's not always possible to agree on everything, but we agreed on risk stratification, and we decided a common treatment. So the BFM decided to use non-anthracycline-based induction, and then they randomized against the standard DI, which is protocol 2 IDA, and pulse therapy with the R1, R2 blocks. And their focus was really that they had noticed increased toxicity in treating relapsed ALL, and they wanted to decrease the toxicity. R3 focused on day 1, day 2 randomization of mitoxantrone and idarubicin. And the main focus of this was to test MRD as a surrogate marker of outcome, because there was early days for MRD, and there was a lot of hope saying, you know, we can actually shorten our trials and shorten the duration of what we do, pick the winner by just looking at what the MRD was. And this was followed by cyclophosphamide etoposide block and a high-dose Ara-C block. High-dose methotrexate blocks were common with the BFM, and also in common with BFM was the time points that MRD was done and the time point for transplantation. And we agreed with the BFM that for late bone marrow relapses, patients who had high MRD levels, the BFM defined this as more than 10 to the power minus 3, and we defined it at 10 to the power minus 4 or more, would be eligible for a bone marrow transplant, and all high-risk patients would go to transplant. Now, the R3 randomization was stopped early on because mitoxantrone proved to be much more effective in achieving long-term cures. And we demonstrated as well that you cannot use MRD as a surrogate marker of outcome as a comparison of 2 different drugs. And that data was published more than a decade ago, and I'm not going to talk about that any further. What we published early last year was a long-term follow-up of the late bone marrow relapses. And what you can see here in the blue line is the outcome of patients who had MRD of less than 10 to the power minus 4 at the end of induction, were treated with chemotherapy alone. They received site-directed radiotherapy only if they had only if they had a site of extramedullary disease. They did not receive cranial prophylaxis. And what you see here is that there's a significant difference in progression-free survival as well as in overall survival between the MRD low and the MRD high group. And this is the MRD high group has been transplanted predominantly. And what you see over here in the overall survival as well is that even with the patients who relapsed a second time, the majority were salvageable with transplant, suggesting the disease retained its chemosensitivity. So the BFM re-looked at their data, and shortly after that, they also published showing that the MRD of 10 to the power minus 4 at the end of induction is the best indicator of how patients will do. And in their study, now remember, they had chosen to transplant patients with an MRD of 10 to the power minus 3 or more. So this is not exactly the same as ours. They also had decided to give cranial radiation as prophylaxis to all patients who didn't get transplanted. And anybody with a sibling match transplant, a sibling match donor was eligible for transplant. But nevertheless, they actually found no difference now at this with this strategy. So vast improvement in previous days when, you know, the 10 to the power minus 3 or 10 to the power minus 4 patients had a very high rate of relapse and poor survival. And what we can see over here is that really there's very little difference between the cumulative incidence or relapse in these two groups. There is an increase in, treatment-related mortality in the MRD high group, and there's primarily related to transplant-related mortality. So we looked again to see in the R3 cohort, what were the determinants of outcome of this group, okay? So obviously MRD we had already shown you that MRD is predictive of outcome, but we also identified cytogenetics as a marker of outcome. And it's much better clearly seen in these Kaplan-Meier curves, where you see this red curves shows a much poorer outcome for high-risk cytogenetics, and Professor Inaba has already talked about this, okay, why they specifically chose, and MRD doesn't pick them out. And this is patients in this category of high-risk cytogenetics were eligible for transplant even irrespective of what the MRD level was, and they still had poor outcomes. So we define high-risk cytogenetics, and just exactly as Professor Inaba, MEF2 wasn't discovered in those days. We didn't know about it. So KMT2A and TCF3 rearrangements, IM21 hyperdiploid. Technically, BCR-ABL1 patients were also eligible as high risk, but in those days, these Philadelphia positive ALLs were primarily transplanted in CR1, so we don't have anybody in this cohort. Low risk are ETV6 RUNX1 and high hyperdiploid, and the rest fall into the intermediate risk category. So we looked again now at the MRD again. So one of the questions I wanted to know was, does the duration of CR1, okay, affect the MRD? And the answer is no, okay? So if you look at patients here, you can see that even patients who are relapsing immediately after stopping therapy do achieve MRD clearance. And equally, patients who have disease relapses 10 years later have high MRD. At the induction. So this behavior doesn't correlate with the duration CR1. So we went back to cytogenetics to say, okay, what is the correlation between cytogenetics and MRD? So if you look at this, so the green is the low risk, the orange is the intermediate risk, and the red is the high risk. And below is the MRD, green is low MRD, the brown is high MRD. So you can see in the low risk cytogenetics, about half of our patients were MRD positive. If you look at the intermediate risk is about 2/3. And if you look at the high risk, it's about 80%, okay? So clearly the MRD positivity rate at the end of induction has a correlation with the cytogenetics. So the biology of the disease is driving the drug resistance phenotype. We also looked at the common deletions or somatic copy number alterations and mutations. And what we noted was deletions of Icarus, PAX5, and R3C1, CDKN2AB, and NRAS mutations were much more prevalent in this MRD group. So they were driving the drug resistance phenotype. And there's a fair amount of biology which actually explains why this might be the case. And these were all statistically significant. So then to summarize the first part of the talk, about 40% of patients with the late bone marrow, BCP-ALL late bone marrow relapse will achieve good MRD clearance. They can be treated with chemotherapy, and those who relapse are salvageable again. The problem remains about the patients who are MRD positive or high-risk cytogenetics, where even after transplantation, we do see a recurrence. And in both categories, you would argue, there is role for immunotherapy, perhaps post at the end of chemotherapy, to clear any residual cells, okay? So I'm going to move on to the high-risk group. So the high-risk group we've defined before. Now, the grand plan with the BFM was that we would complete our clinical trials at the same time, and then we would merge into one trial, which is now IntReALL. But the R3 randomization closed early. So this gave us a chance. So just like you are very excited about blinatumomab and CAR-Ts, we were extremely excited about clofarabine. And SEMA led the development of clofarabine in those days. It was the wonder drug at that time. So we said, well, let's try clofarabine then. So what we did was we took the cyclophosphamide etoposide consolidation block, added clofarabine to that, brought it into induction, saying we need better MRD clearance in these patients. And we took the mitoxantrone block to the second the consolidation block. So basically, the patients got all the same drugs with the addition of clofarabine. And that allowed us to compare 4 different regimens. So not exactly different, but slightly different, okay? As you can see, with the exception of idarubicin, actually the EFS and OS is very little different between clofarabine, mitoxantrone, or the BFM approach. And in fact, mitoxantrone did better than clofazimine, okay, overall, and clofazimine was much more toxic. So this wasn't the result we wanted, because obviously it's suggesting that primarily this disease is highly drug resistant. So chemotherapy, cytotoxic therapy is not going to change the outcomes of these patients. So along with the BFM, we decided to merge all our data together to try to make sense of this. And what we found was this. So across all the treatment regimens, the same thing happened. About a third of patients don't enter remission. They fail remission, okay? And then as they go through, you find this group of patients, about 10% of patients relapse before they even get to transplant, even though they've achieved remission. And this cohort is comprised of two groups, which Professor Inaba has already described: B cell with high MRD and T who are MRD clear, they relapse, okay? And so MRD doesn't give you an indicator of how T cell disease is going to do, perhaps because there is a huge extramedullary reservoir. We don't know. Okay, so we'd like to see, okay, could we find any determinants of who was going to fail induction? And that found older patients were likely to achieve, not to fail induction. So this is the 12 years and above. And here duration of CR1 did make a difference. So, and this is primarily the patients who had relapsed within 18 months of diagnosis were more likely not to achieve a CR, okay, highly drug resistant. We also examined for the genetic subtypes, and again, we found Icarus and the glucocorticoid receptor genes, PTG and R3C1, and also a deletion of BTV6. So then we looked to see, okay, what happens to these patients who actually get to transplant? So you can see about roughly half get to transplant. So you've lost half your patients before you've had a chance to transplant them. And if you look over here, you find that of the few who didn't get transplant, outcome is actually very poor. However, there's always a confounder. 2 patients have survived and are alive without a transplant. And median follow-up of this is now 8 years, okay? So, okay, there's always a confounder. But if you look at the transplant group, there's a sobering lesson here. 14% died of transplant, okay? 30% relapsed. So overall then, of the patients who were transplanted, there's half will survive, okay? So we said, okay, let's look at this group again more closely. Where was the TRM and where were the relapses? So if I show you this, so just look at the green colored lines first. This is showing you the cumulative incidence of death in transplant. And you can see that there's a significant increase in deaths in the TLL compared to the BCP-ALL. And we don't actually have an adequate explanation for this, except for the fact that this has also been observed in a large retrospective analysis of T-cell relapses transplanted in America. It's a multi-center study which was published here, also showed exactly the same result. And then we looked at the relapse rates, and you can see the Ts hold their, if you don't kill the Ts with the transplant, they actually hold their remission. It's the Bs who relapse, okay? So there's a high incidence of relapse in the Bs, okay? So it's almost 37%, okay? So we decided to look again closely at the B to say, are there markers that tell you why a B cell, BCP-ALL is relapsing? The first indicator we found was the kinetics of the MRD response. If a patient had less than 10 to the power minus 4 at the end of induction, really coming down to below the level of detection now by RGTCR, or if the level of disease was below 10 to the power minus 3, but the patient subsequently before transplant achieved a level below 10 to the power minus 4, which we classify as MRD good group, the outcome in this group is 66%. Okay, so if you can get these patients to transplant, and you have a good MRD kinetics, okay, these patients actually have good, decent outcomes in this high risk group, okay? But if the MRD persists, okay, then that's bad news, okay? And we also found that a pre-SCT MRD of less than 10 to the power minus 3 and the presence of acute graft versus host disease, okay, also were indicators of good outcomes. About 12% of these patients had a rearranged P53, and these patients do very poorly, 17% outcome. And again, we did not identify any markers that could say that prognostic for T was only for B. Now, this is showing you the outcomes of patients over 24 months for both B and T. So this is a patient who achieved CR2. And this is block 1, block 2, block 3, block 4 is a SCT. And the reasons I'm showing you this curve is for 2 reasons. One is, this is T and this is B, and you can see it's exactly the same outcome for B and T, okay? The second reason I want to show you this, and I should have told you this earlier, if you look at this curve, so this medium follow-up is 77 months, and the curve plateaus out at about 2 years, okay? After that, it's relatively stable. So if you look at this, it's for 24 months. So the data that is being presented now for blinatumomab and CAR-T does not have this duration of follow-up. Immunotherapy will achieve a better MRD, and you could argue that it will delay the relapses. So to be really confident about the immunotherapy, we do need longer follow-up. So to summarize the part 2 is that immunotherapy really does provide a great hope for this group of patients, because a third don't get into remission, and about half of those patients who are transplanted relapse. But it doesn't offer a hope for those third that don't go into remission. So we do need better therapy for that, how to get patients into remission. Because as Professor Inaba has told you, if you treat patients who have a bulky disease, you have much more toxicity and not as good outcomes. So the other thing that Professor Inaba also showed you was the issue of toxicity. If you use the same kind of treatments that you use in the West, if you use that in low and medium income countries. And certainly when we try to use R3 in India, we face the same problems, okay? So we modified R3. What we did was we already knew from preclinical data and early phase clinical trials that adding bortezomib to induction was associated with better CR rates or CR2 rates in patients with more resistant disease, both B and T. So we added bortezomib to induction, but we were worried about the neurotoxicity, so we removed vincristine. And rather than give bortezomib every 72 hours, we gave it weekly. The second area that block of therapy that we had noticed an increased toxicity was with the high-dose cytarabine arm, which is the intensification arm. And we felt that the dose was too high, and that for patients who had isolated extramedullary disease or who had cleared MRD, we didn't need so much cytarabine, we didn't need 2 weeks of cytarabine, so we just gave 1, okay? And this is more updated data to show that actually what we're achieving now is good CR rates in the high-risk groups with a decent MRD clearance. The data is quite small, but this is a lesson that we learned, and this is the out survival outcome. This is published again, sort of middle of last year in BJ. So if you look at this curve, okay, so what happens there is that treatment is expensive. And when we first started treating patients with relapsed ALL, many of our parents didn't want it because they felt this is experimental therapy. Many couldn't afford it. This has now changed. Many more people want it. So those patients who couldn't afford treatment, we treated with vincristine, steroids, 6-mercaptopurine, just to keep them supportive. Median survival in this group is 2 months. Most of them were heavily dependent on hospital and platelet transfusion, as would be expected. This group up here is the 100, which is showing 100%, and this has remained remarkably stable at a 2-year follow-up. It's a group of patients who don't need to be transplanted. So there are late isolated extramedullary or late isolated medullary who have cleared MRD. Again, numbers are small. This is the group, this blue and orange are the patients who need to be transplanted. The blue, which is the majority, cannot afford transplantation. But what we've seen is that if we treat them intensively, as we have outlined, they maintain remission, they go back to school, they go back home, they don't come to hospital, and they have a good quality of life. The patients here who are transplanted, all high-risk patients, so the outcomes are pretty much what we would expect. What about toxicity? So look at the toxicity here. So if you look over here, there are no grade 4 toxicities. Induction, there were 2 patients who died. They were high-risk patients. One was probably not in remission at the time we took this patient into treatment, and one patient relapsed shortly after consolidation and the frontline treatment, so very early relapse. But the rest have been well tolerated. And if you look over there, it's all the way down to here. It's fairly reasonable. But the lesson is really here. Look at the hospitalization. So we treat all our patients as daycare, unless they're unwell. They're admitted only for complications or for chemotherapy for cytarabine and high-dose methotrexate. So the average duration of hospitalization for complications was 4 days here, 4 days in consolidation, 5 days in intensification, but it shoots up when you give 2 blocks of cytarabine. So you intensify, And remember, the cost of treating complications is far more than the cost of actual chemotherapy. So then, to summarize this part, we have established and piloted what to us is a very successful strategy for relapse with good outcomes in the low risk group. And I think that really my patients are poor. So if you look at this budget my budget is $5,000 to $10,000. $5,000 is what most people can afford, maximum $10,000, okay, for treatment. I cannot go more than that. And my patients may be uneducated, but they're all very knowledgeable, and they all come to me when a child relapses and says, if we were in Manchester, we would be getting blinatumomab and we would be getting CAR T cells. Why aren't we getting it here? So I'm very grateful then for the intervention and collaboration with St. Jude's Global and to allow us to actually make this happen. I'd like to, I realize we've overshot time. There are many hundreds of people to thank on this journey. My colleagues at the BFM, Anthony Moman, the ALL cytogenetics group, Katrina Parker, who managed the ALL R3 database for many years, and of course, my team at Kolkata, who have now taken all this forward, and many, many people who have funded these projects all over the years. Thank you very much.
Thank you, Professor Saha. We have about 10 minutes, I think, for some question answers. The first question goes to Professor Hiroto Inaba. It comes from Dr. Chetan Dhamne in TMH Mumbai. Ruxolitinib, Hiroto, you showed that ruxolitinib was being used, added on day 43. So Chetan's question is why you're using it day 43 and why not earlier? Is there any biology behind this?
So we use ruxolitinib for JAK-STAT alterations. And then many of the JAK-STAT alteration can be found by RNA-seq. So some pop up on day 15, but comprehensive analysis such as point mutations, these cannot be identified by RNA-seq. We need a whole genome, whole exome. That's why at least it takes 28 days. And our induction therapy is 42 days. So we decided to use ruxolitinib after the induction for these patients. That's, practical reason, to identify all, we need a comprehensive analysis. That's a, just practical reason, no biological.
Okay, great. Thank you. Next question is to Professor Saha. It's from Shamriti Sen, asking about the late relapses. So those patients who relapse late after 3 years. What's the role of combining chemotherapy and immunotherapy, and which group you really would need to combine immunotherapy in these late relapses?
So I think I addressed that in my talk, that in the late bone marrow relapses, MRD splits it out very nicely. And patients with chemotherapy who are low MRD have a good response, with chemotherapy have excellent outcomes. There are fairly decent outcomes with patients who are MRD positive, but they need to be transplanted. So role of immunotherapy, my guess is it should be applicable to all, because I think what Hiroto's slide says total cure, right? And so 100% cure. So we are not at 100%. So I would give it to, so just like the issue with CAR T is going to be much more difficult to deliver. But my question is that, the late relapses we had, and those were MRD negative. The logic would be MRD positive, you give it to blinatumomab and you go to transplant to get a better transplant. But I would equally argue that perhaps it may be something we can evaluate, and which cannot be evaluated in the West, but can be evaluated in low-middle countries, is you give it blinatumomab also to the MRD negative group, okay, and see if that improves their outcome, because it's analogous to what Hiroto wants to achieve, which is give CAR T and no transplant. Okay, maybe it has the same effect. We don't know. So I would give it to both.
Okay, great. The next question is to Professor Inaba again from Stella Chai. Why did COG put inotuzumab in the high risk and blina in the standard risk? What's the rationale behind it?
Yeah, I'm not a COG member, and I asked Dr. Hanga one time. I don't think there's, specific I couldn't understand for specific reason, but you know, I think there was. I don't have a good answer for that. I'm sorry, I'm not in the COG member. I maybe if I can guess it, but I don't want to give a wrong message. So actually, I have to ask the COG members.
Okay.
But yeah.
I have another question from Yuan Lin Liu. I think should go to Professor Hiroto Inaba. Question is, I would like to ask about the using blended relapse ALL with MLL rearrangement. Is it inevitable to see lineage switch? Are there still some roles of anti-CD19 as a bridging agent?
Yes, so no, I mean, it still can be used, maybe effective, yeah, but we are just afraid to see case reports that, you know, just pushing CD19 as a pressure, maybe there's a escape for the myeloid lineage. So we have seen case reports. That's why we are, you know, holding to use it. You know, recently other agents for MLL, such as venetoclax, or you know, or other menin inhibitors, many new agents are getting available for MLL. So hopefully, this one can be, you know, become available and we can use for MLL side. So you know, we don't know yet, but we just scared about lineage switch. That's why we didn't use it.
Great, thank you. The next two questions actually goes to Professor Saha. First one is from Subramanian. Any reason why the clofarabine cycloetop did not work?
Yeah, so at least this is my concept, is that drug resistance is an evolution. So you're getting clones that are evolving, and this has been clearly shown by Charles Mulligan's group. So in many of these are clones which are present at initial diagnosis, which have now become a dominant clone. So let's assume that drug resistance, mechanism of drug resistance in cancer is often an ability of the drug of the cell to tolerate cytotoxic stress. It doesn't matter what drug you give, they will be resistant. Okay, and I think this is what it shows. Doesn't matter what drug you use, the cells will not die. Okay, cytotoxic drugs. So you need another way of killing the cells.
Okay, great, thank you. The next question is from Prasad to Professor Saha. The T-cell ALL relapse, is there any data to say nelarabine-based therapy will achieve better MRD clearance than the R3 approach?
So what's it called? The COG have done a fair amount of work with nelarabine, and they actually didn't have very good results with the relapsed TLL, but frontline TLL they have shown has a much better outcome. Okay, so the sensitive Ts, but you know, in the UK, outcomes of T itself is more than 90%, 95%. I'm sure the same in St. Jude's. So it's a vanishing small amount of patients that you're looking at. In relapsed ALL, when they did it, they didn't actually get any better results. We tried clofarabine in T as well, and we didn't get much better results. Of the newer drugs that are available in T, so T is disappointing in the sense it hasn't advanced to this exciting arena where we are with B. Nelarabine is a possibility, but they're new. Venetoclax and navitoclax, which Professor Inaba was talking about, is showing some promising. So the BCL2, BCLXL inhibitors. Daratumumab, which is the anti-CD38 antibody, is also being looked at. And there are some approaches to try CAR-T, but yeah, no, T remains the challenge.
Great, thank you. Maybe I put the next question to Professor Inaba from Koite. If a center can only use flow MRD, will that be as good as IgH TCR or immunoglobulin PCR or TCR? T-cell receptor PCR, will that be?
Yeah, I think flow has more, you know, we can test more patient than immunoglobulin T-cell receptor, but both are proven excellent, you know, monitoring for MRD. So either way, I think fine. And so, but when you use immunotherapy, flow MRD, you need to be very careful. For example, when you are targeting CD19, CD19 should not be used because antigen may escape. So, you know, Ig, TCR, PCR, or NGS can be applied even you are using immunotherapy. So that's a benefit to use in the use of the immunotherapy. So I think both are comparable.
Okay, the next question is from Chintan to Professor Vaskar Saha. For low-risk ALL relapse, is post-induction MRD is the only way to decide further treatment? Time point 2 MRD, would that be of much use, especially in resource-limited setting?
So, Chintan, the vast majority of your patients will be negative at time point 2. So you will be forced to transplant everybody. Anybody who's positive at time point 2 is bad news. So you can't identify who shouldn't be transplanted if you do an MRD at time point 2 only.
Okay, great, thank you. Maybe time for one or two questions. There's a question for, I'll put it for Hiroto, from Motohiro Kato. Do you have a plan to adopt blinatumomab in the lowest risk group to reduce chemotherapy agents?
Yes, so this is a great question, Motohiro. I think we have to start from the higher risk, of course, and then hopefully we can reduce chemotherapy. At this moment, many people think low-risk leukemia can have a very good prognosis, even low intensive chemotherapy. So many people are not interested at this moment to bring this immunotherapy for this patient. However, I think if we want to consider chemotherapy-free regimen, that is one possibility. And then hopefully after success if confirmed success in the higher risk patients, we may be able to bring to. And then also the other question was, immunotherapy is very expensive. And then, I think collaboration with company or, some funding agencies is very important. And luckily, Amgen is very committing to long-term for these countries. So hopefully we can bring to this, immunotherapy expensive one to the everywhere in the world.
Okay, thank you. Maybe I take one last question is to Professor Inaba. Any data to show convincingly that blina only delays the relapse as compared to CD19 CAR? So the blina needs a VMT where the CAR T may be used without VMT.
The answer is at this moment, for the blina, we are using blina followed by chemotherapy. So we are not decreasing much about chemotherapy, so I hope blina enhance, but to answer this question, I don't think we have a long term enough to show this is, truly curative by itself. And then CAR T cells, still we have a very limited number, and then we don't have, maybe we have 5-year max for the follow-up. So this is still we need for safety issues, long-term issues. So still, we need to answer many questions, many research is needed.
Okay, thank you so much. I think we have run out of time. So thank you to the both speakers. I'm going to hand it over to Anson from Viva to close the webinar. Anson?
Yes. Yeah, thanks, Professor and doctors for all your contribution and sharing. Okay, okay, for the sake of some of the audience who may have logged in just now earlier and may have missed my little short opening, my name is Anson Chu. I'm the Chief Operating Officer of Viva. At this juncture, I'd like to kind of like conclude our webinar for the evening, and then thanks everybody for tuning in. I'd like to also say a very huge thank you to our presenters, Professor Inaba, Professor Saha, and also Dr. Rajat. So this entire seminar this entire webinar is possible also because of Amgen for their support with the education grant. We also would like to thank them for their support. And finally, for the audience, I hope all of you have found this seminar extremely useful. We would like to also hope to see most of you or some of you attending our next webinar. I will now pass the floor to Teresa, who will do the administrative closing, and she can share a bit more of our next seminar. Thanks.
Okay, hi everybody. I'd just like to invite everybody to share your feedback. There's several ways to do it. One, you can scan the QR code on your screen, or after you close the Zoom chat, then it will automatically take you to the survey screen. So it would help us to improve if you could fill that in. We'd also like to invite everybody. We have about a lot of webinars coming up in October. Immediately on the 2nd of October, we have one on the current concepts in the biology and treatment of LCH with Dr. Carlos Rodriguez Galindo from St. Jude, as well as October 14, which is on state-of-the-art immunotherapy in ALL with Professor Elias Chabor from the MD Anderson Cancer Center and Dr. Jay Park from Memorial Sloan Kettering Cancer Center in the US. You can find all of this on the Viva website at www.viva.sg. And with that, I guess we can end for the evening. Thank you everybody for coming. We hope that it was useful for you. Good night.
Thank you so much.
Thank you.
Bye-bye.
Thank you everybody.
Thank you very much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.